as we move sort of, let's talk about what's out there on the horizon. So we're talking about what's approved from an immunotherapy standpoint. Again, I think immunotherapy is pretty exciting. Neal, I just read, recent monograph you wrote about immunotherapy. So what else is out there, from a vaccine standpoint, from some of these checkpoint inhibitors? What other drugs are out there that are being talked about specifically for immunotherapy?
In 30 seconds or less.
Yes, absolutely.
It's just an incredible time right now. I mean, there'll be a lot at AUA this year and certainly at ASCO. I mean, immunotherapy is sort of at this point coming really into its own. And to your point, there are therapeutic vaccines, the Cipula cell T. There's an outstanding phase 3 trial right now going on, known as the PROSVAC trial, where we look at the various mix of 3 different antigen molecules to stimulate the immune system, given subcutaneously. And then there's this whole field of the checkpoint inhibitors, which are the CTLA-4. This is a drug called ipilimumab, now approved in metastatic melanoma. It's been trialed in metastatic prostate. There are other checkpoint inhibitors known as program cell death, ligand-1 and program cell death, kind of cool sounding names, but what the checkpoint inhibitors essentially do, as opposed to a therapeutic vaccine, is they take the brake off of the T cell. Kind of teleologically, one would think about this as we have checks on our T cells so that we don't develop autoimmune disease and immolate, and turn into a big ball of pus. By controlling, taking off those checkpoints, we turn on our T cells. And the thing that's very sexy about it, and I love to throw that in when you're talking about advanced cancer, how often can you use the word sexy? But what is sexy about it is the combinatorial possibilities of checkpoint inhibitors with vaccines and other hormonal therapies. So it's amazing what's going to happen, I think, just to make our options even more complicated, but yet in a great way. And these therapies are, by and large, these other immune therapies continue to be well tolerated and with unique mechanisms of action. So I think our audience needs to be watching and listening to all this data that's coming out.
Yeah, I think as our friend Chuck Drake says, that these checkpoint inhibitors, basically you take the brake off the immune system. I think that's the easiest way to look at it.
It also seems as well with these newer treatments, we're moving away from treating the cancer, but more addressing the patient's immune system. And I think there's a very exciting time there, particularly we know that African-American men who tend to have more aggressive disease, they tend to present at a younger age, they tend to relapse sooner. I think there are clear molecular targets out there that we are still yet to discover, but it's an exciting time for addressing receptors and immunotherapy for these patients who have this very aggressive disease.
No, I think that's well said. I think we're moving away from saying this is prostate cancer, this is breast cancer, this is lung cancer. What we're looking at, there are particular targets and pathways, and in this case, it happened to start in the prostate. In this case, it happened to start in the lung. And so by targeting these pathways, that's why I think we're seeing this crossover of therapeutics that, like you said, like ipilimumab, it's approved in melanoma, but we also know, hey, it may have a role in prostate. And I think, that's kind of where we're coming to. Oliver, you're very up to date on all this. What about, are there any other newer hormonal agents, other drugs that are out there besides immunotherapy where people are looking at it? I know the one that everybody's talking about is Aragon 509.
Yeah. Actually, there's a lot of them right now. The ARN 509 came out of Charles Sawyer's lab, the same fellow who invented the enzalutamide. Very, very active agent in the phase 1. It's now in an M0 trial in a placebo control. There's another one from Finland called ODM-201, and it's another quite active anti-androgen. And then enzalutamide itself is going into that early space, M0 space. So there are a variety of these new androgen receptor targeted agents. There are also new agents that are being looked at in the androgen synthesis way, or Tylenol. Now they've had some trouble in terms of being able to hit overall survival in their phase 3s. But it's part due to the dilutional effects of all the active agents that are being given post-protocol. And I tell you, that's a huge issue right now in terms of CRPC, because we have so many active agents. How do you isolate one and then show a survival benefit? Right. And this is a big issue. But there are other ones as well. You may or may not be familiar with glatterone, so the TOC001, another active compound. So You know, it's a very exciting time in terms of hormonal therapy as well as immunotherapy. A lot of evolutionary changes, and of course the trials just have to play their way out.
Right.